So we're going to go ahead and switch up here and open up our clinical symposium for current clinical trials in neurotrauma. And it's my pleasure to invite Dr. Peter LeRoux to come up and talk to us about the active clinical trials. And after this, we're going to have a little bit of debate. And I see that now that Dr. Marshall's arrived, I'm sure this will be a spirited debate as to whether or not we should even bother anymore with clinical trials and TBI. So with that, Peter.
Thank you, Jeff. I'm going to try and overview in a very short period of time a lot of data, and obviously this presentation is not mine alone. It's actually David provided me help because on Monday he reminded me I needed to do this talk. I was due to be flying back, so I'm going to fly through this talk instead of flying home to Philadelphia. We also got on slides from Ross Bullock, Peter Hutchinson, Jamie Cooper, and a variety of other people. So this is a presentation that acknowledges all of their work. We do know that traumatic brain injury is common, and certainly it's a lot more common than those diseases that we hear frequently, breast cancer and HIV. Most of what we see as neurosurgeon is the severe TBI, and that represents about 10% of traumatic brain injury. So there's a lot of focus that can be put on mild and moderate head injuries. The importance of head injury is it's common, about every 15 to 20 seconds in the United States. What is very interesting, though, is it's the greatest cause of death in all males under about 40 years of age worldwide. And more importantly, in children, it is the leading cause of death and disability for children between the ages of 1 and 15. It's not malaria, it's not TB, it's not what Bill Gates will tell you about. It's traumatic brain injury. And the long-term cost is in the billions of dollars, $50 to $60 billion in the United States when you look at disability. Now, the decade of the brain prompted a lot of work, particularly by pharmaceutical companies, and led to many randomized controlled trials. This was a summary from an NIH consensus which was published in the Journal of Neurotrauma in 2002 with Raj Narayan as the lead author. A lot of randomized trials, but no single therapy had been found effective. So that led to a certain amount of nihilism within the pharmaceutical industry, and not many want to pursue the concept of drug therapy. Some do, but there are some promising drugs. For example, Pfizer had a great glutamate antagonist, and they just dropped it because they didn't see it as being economically viable. Now, there are reasons why those trials failed. Some of it had little to do with the efficacy of the drug, but more to do with the trial design. So, for example, some trials that went into phase 3 had actually never documented that the drug even made it into the human brain. Secondly, there were dosing issues, and as David Menon pointed out in a beautiful article in Critical Care Medicine earlier this year, almost none of the trials were powered sufficiently to define a minimally important difference. And what the NIH is interested in now is not so much that you can demonstrate the reason why the drug works or the academic or intellectual side of it, but do you have a therapy that demonstrates a benefit? Is that benefit enough that the clinicians will change their practice? In other words, what's the minimally important clinical difference? We surveyed the Neurocritical Care Society. It's somewhere between 5 and 10%. So on the order of 8%, if you have a reasonable design trial, it's going to be about 1,400 patients. If you drop it down, as Gordon Murray suggests, to the 1 or 2%, you get something like CRASH, which is 20,000 patients. On average, a trial is $10,000 per patient, so you can see the exorbitant costs involved in doing trials. Another reason why the trials have perhaps failed is we are somewhat simplistic in our classification of traumatic brain injury. We use a Glasgow Coma Scale. In essence, that's a symptom. There are not many other disease states that are classified by a symptom. And if you think about why the Glasgow Coma Scale developed, it was in the mid-1970s to determine which patients in the United Kingdom should be triaged to a center with a CT scanner. It wasn't done for any other reason. In our institution now, partly because of how the EMS services work, every severe TBI is a GCS of 3. So prognostically, we do great because our GCSs of 3 do well. What's better predictive is the Apache score or the SOFA or the MOD score, which is looking at their premorbid condition and their physiologic variance. And this has led to a reevaluation by the NIH, and I know Jeff was involved in this, and Kathy Sutton was the lead author, published last year, about how can we better classify TBI? How can we better define it pathologically or with biomarkers so we can now target therapy to specific disease states, not just to a GCS of less than 8. This may require sophisticated neuroimaging. It may require sophisticated biological approaches. But despite that nihilism, I think one can have a certain amount of optimism. We know that heart is successful in AIDS. It took 600 trials to get there. So we're only a third of the way, and I think we can be optimistic that ultimately we will get there. We all recognize the secondary cerebral cascade that evolves after traumatic brain injury. There's usually not much we can do about the primary injury as physicians, but an immense amount about this. And each of these entities, if you find a specific drug or biological compound, you will effectively ameliorate the condition in the laboratory, but not necessarily so in the clinical realm. So we don't have effective drug therapies. And it might be naive to expect that we will have a single drug for TBI as a whole. It might be better to realize that we have a process of care similar to ARDSNet, or that we have multiple drugs that can work on multiple systems, or single drugs that are very targeted to diseases that are selected perhaps to the individual, to the gender, to the weight, to the pathology, and so on. So here are some of the trials, and this I must say is a real partial list. There's a lot going on. I'm going to try and focus on some of the larger phase 3 trials. Factor 7 finished just recently. Solvay is still ongoing. Progesterone or Protect is about to start through the net. Acetylcholine is ongoing. Decompressive craniectomies through DECRA and Rescue ICP are ongoing. NABISH-2. There's a hypertonic saline study. Cyclosporine may start under ABIC. Ross Bullock is trying to get the Oxycyte PFC trial going. There's a phase 2 brain oxygen trial that is now funded by the NIH, and the phase 3 boost is going through the NIH. The DoD is looking at beta blockers and statins and so on, and there are a variety of other possibilities that may occur in the future. What is important is the collaboration, and here are some of the consortia that exist. There's the clinical trials consortia that one of this has got CDP choline and COVID in it. NET, which is really through the emergency room services. I think on our 17 major centers, and from each of those centers, there are generally about 8 or 9 spokes that develop, so a large number of centers. Heart, Lung, and Brain Institute, they're looking at hypertonic saline. The DoD consortia that exist. LABIC, which Randy Chestnut and Nancy Temkin are trying to push. We've established a brain oxygen clinical consortium. The Neurocritical Care Society has now come online with a clinical trials group. The first research conference will be in Houston later this year, and that's been funded by the NIH. Wonderful group in Australia and New Zealand. I think they're a great group because they're meeting, and it's always worth going to. It's in Noosa, which means you sit on the beach, nobody wears long pants, there are no ties in sight, and you drink beer while you discuss it. When you think about it, you know, they've got DECRA, they got one coming online, they did nice sugar, they did a hypertonic saline trial. Great collaboration there, easy going in Australia and New Zealand. There is ABIC and EBEC as well. We do have guidelines, and guidelines, I think, form the basis for many of our clinical trials. One has to recognize that these guidelines are really a literature review because there's very little in the way of randomized trials. Now, I'll tell you one of the most elegant lectures I've ever heard was by David Tobin, who's the editor of the American Journal of Respiratory Care and Intensive Care. And in essence, he said randomized trials are a bunch of hogwash, because what we do as clinicians is usually based on our intuition, our knowledge, our understanding of pathology and physiology. And what a randomized trial does is validate what we know from a physiologic and pathologic standpoint. One of the first randomized trials in neurosurgery was by Sir Wiley McKissick in England, comparing aneurysm surgery versus no surgery, and the patients who did better had no surgery. Now, none of us listened to that. We still did aneurysm surgery, and now we do coiling. But the reality of it is randomized trials are but a small component of our necessary knowledge to evolve care. The guidelines provide the basis to which we can compare. Let's look at some trials. There's Protect. David Wright is the main PI of this, coming out of Emory and Grady Memorial Hospital. There's a lot of research, preclinical, in many different animals and animal models suggesting that progesterone is of value. I will not go into a large amount of the science. They did a small phase 2 trial with 100 patients, so 4-to-1 block randomization, so they're not a large number of patients with placebo. They did demonstrate that those who got progesterone had a much greater likelihood of favorable outcome. And hence, Protect 3, or the phase 3 trial, has started going through the net, and they're going to look at an improvement of a GRSE at 6 months. They will also look at mortality and DRS. These patients have to be enrolled within 4 hours of injury. It's not a wide therapeutic injury. They're looking at waiver of informed consent, trying to get about 1,100 patients. Now, waiver of informed consent is very difficult. If you try to look at it, it is a major undertaking, and it varies from state to state. The idea here is to infuse progesterone over approximately 72 hours. Cyclosporin may well come online. There's a trial that's going into review with the NIH. Dave Onkonko, John Pavlashok, and others have shown in preclinical studies cyclosporin can ameliorate much of the axonal dysfunction and perhaps also the mitochondrial dysfunction. And here you can see that in a simple histogram. I won't go into the details of this. The value of cyclosporin is it's FDA approved and known to be safe. A small study, phase 2, was done at MCV and the University of Florida. This is 58 patients. A subsequent study at the University of Kentucky. In essence, these did not demonstrate clear benefit, but demonstrated that less presses were needed and better perfusion pressure. And if you recall Claudia Robinson's study from the late 1990s, that may well be of value. Now there is the CAS-TBI trial going through ABIC with Byron Young and others. Again, this information here may not be completely accurate because it's now in revision, and I believe rather than severe head injuries, the study section is asked that it include moderate head injuries and such things as the sliding dichotomy or shift analysis to look at outcome. This, again, is going to have a fairly large number of patients, about 1,200. So you're starting to look at trials that at least have 1,100 to 1,200 patients. The primary outcome, again, is going to be GOS at 6 months. There is a phase 2A trial through Solvay looking at this agent. Smaller sample size. This is an endothelin antagonist. The value of this, and it's considered a neuroprotectant, is it may also have an anti-apoptotic effect. This is running out of a French pharmaceutical company. The value of that is to widen the therapeutic window. Temperature. Now we start moving away from drugs and looking more into process of care or biological type therapies. We all know the deleterious effects of fever and the potential benefits of hypothermia. And Don Marion demonstrated some 10 years ago in a small single central study that there was value to hypothermia. There also were very large number of studies that had demonstrated the improvement in intracranial pressure, so our current guidelines will use that as a second tier of therapy. However, Guy Clifton demonstrated in NABISH-1, or rather found, no benefit to hypothermia. And this was a well-done study, but there was one major limitation. That was standardization of management was not necessarily complied with within the centers. In subgroup analysis, they did find that the younger patients did better. And hence that's led to NABISH-2, which is ongoing on a variety of centers. Perhaps this is the reason why it's Calgary and Edmonton, because it's always cold up there. But it's going on. It's a different study. It's perhaps a slightly different paradigm in TBI research. It's now targeted to a smaller group of patients. The younger patients, which are NABISH-1, were found to be where it was effective. And a short time after head injury, 2.5 hours, that's not a long time, after emergency room arrival. But it is a slightly new paradigm. And this includes emergency waiver of consent and the use of pre-hospital enrollment by the emergency medical services. And most importantly here, this concept of uniform ICU management. And Guy Clifton and others have been very strict about protocol compliance. It's a small sample size because you've got such a select population. And this is what comes up into the design of trials. Very large with a heterogeneous population such as CRASH, or target to a very specific group. In other words, an acute subdural without anything else on CT. No contusion, no swelling. Or an acute subdural with swelling, or a select age group to see what then may work. COVID is ongoing. It's a clinical trials network, and there's a variety of centers involved. Yeah, I think it's about 10 or so. The enrollment is a little bit behind projected. The trial is looking at citicoline, and this is more governed through the rehabilitation medicine services because the drug is administered for about 90 days. It's not something just given in the acute phase. It's not a neuroprotectant. It's looking more at neurorecovery. And the idea behind that here is that it can have a neuroprotective effect, but there may also be facilitation of plasticity and recovery. Here are the inclusion and exclusion criteria. I will not go into those in detail, but you will notice here patients with underlying other neurologic disorders are excluded, as is common in many trials. Patients getting other acetylcholine esterase inhibitors similarly are excluded. There's a variety of management issues looking at laboratory work, etc. The most important here is the primary outcome as a composite measure. This is taking a variety of neurocognitive factors to look at outcome. This was done by Nancy Temkin in the recent magnesium trial out of the University of Washington. They did not find a change in outcome in that trial. But this is stuff that is, some of these domains that are being looked at are within the NIH toolbox, not all of them are. We might see a standardization of those cognitive functions as that NIH toolbox is validated during the next 18 months. The secondary outcome is looking at survival. There's COSPID, coming from Anthony Strong in King's College in London. The idea behind this is to look for cortical spreading depression. And this would be a spreading depression or short circuit between the neurons and the astrocytes. It is postulated and has been demonstrated in animals that this spreading depression can lead to secondary neuronal injury. Somewhat synonymous with this is the work that Paul Vesper and others have done with continuous EEG, demonstrating non-convulsive seizure disorders. And the primary objective of the study, which is observational, it's not therapeutic, but the primary objective is to try and figure out if that spreading depression, both its incidence and severity, is associated with outcome, and therefore can we use that monitoring to guide the therapy of the patient or prognosticate. Here's an example of spreading depression. The inclusion criteria here include patients with both moderate and severe head injury. All of these patients will have had a craniotomy. And here you can see the idea is to place a strip electrode, FDA-approved strip electrode, and then look for the spreading depression. A smaller trial that's ongoing through the Heart, Lung, and Brain Institute is the concept of hypertonic resuscitation.
Peter, I learned today that was stopped for futility.
Oh, well, good. Interesting, because I was just about to say that the Australia and New Zealand Intensive Care Society group had done the study, published in JAMA, and shown that it didn't work. So
It was stopped.
At least the trials are giving you the same result. I won't go into the details of that. Claudia Robinson has been looking at erythropoietin. When I last spoke to her, I think this was on hold because of some FDA concerns. Is that correct?
Off hold now.
It's off hold now. And the idea here was to see if erythropoietin could either be neuroprotective or stimulate hemoglobin concentrations. And there are different triggers here. I mean, you do know there's an immense amount of debate about what is the appropriate trigger for transfusion. There's been a shift in general critical care to 7. Whether that applies with neurologic injury is not certain. Well, what about intracranial pressure and moving now more into process of care? Well known that high ICP, and particularly persistent ICP above 20, is associated with mortality, but not necessarily whether there's functional or non-functional outcome, and nor do we know whether treatment of ICP actually makes a difference to outcome. There are some observational studies suggesting that we don't need to do this, coming out of Europe and that. This is some data that's not been published yet. It's by Sherman Stein, who's a colleague of mine. He did a meta-analysis taking 120,000 subjects from the literature. He divided them up in a low-intensity treatment, which meant very few got an ICP monitor, and Brain Trauma Foundation guidelines were not followed. And high-intensity, which was ICP monitoring plus Brain Trauma Foundation guidelines, a significant reduction in mortality and a significant increase in favorable outcome with this high-intensity therapy, and that change was independent of time. So fairly powerful statistics suggesting that ICP care will make a difference. Randy Chestnut and Nancy Temkin are trying to address this problem. Interestingly, the study is occurring in Bolivia and South America. It's not something that appeared to be possible from an ethical standpoint in the United States. There are several components to this. Part of this is capacity building, developing LAMBIC, or the Latin American Brain Injury Consortium. Again, a great group of people to get together with. When you're meant to have lunch at 2 o'clock, it generally starts at 8 p.m. and you keep going till 2 a.m. So a huge amount of discussion occurs as you eat and drink. There are 2 components to this trial. In Bolivia at 3 centers, does the use of an ICP monitor decrease length of stay, incidence of medical complications, and the primary objective, improve treatment outcome? There'll be about 324 patients in that study. You'll notice here admitted within 24 hours of injury. The secondary objectives, which occur through 7 South American countries, are then to see whether that information will generalize. Is there an outcome association with resources? And that's 570 subjects. Well, the concept of decompressive craniectomy is being revisited. This is something that existed 100 years ago. The idea behind that is to sort of get rid of this vicious cycle of swelling leading to more secondary cerebral insults, whether it be unilateral or bilateral. Now, there's a certain impetus for this because of the data from the stroke trials. This is the pooled analysis from Decimal, Destiny, and Hamlet suggesting that decompressive hemicraniectomy is valuable in stroke. This is a slide that Peter Hutchinson sent me. He's the lead investigator in Rescue ICP. You go back some years, the mortality after decompressive craniectomy was more than 50%. Now it's in the 20% range. We're starting to see favorable outcomes. Some of this is related to technique. The current guidelines suggest that this is an option in people with diffuse swelling and medically intractable intracranial hypertension. So it requires ICU monitoring. I think there's been a shift, certainly in our practice, to do these early. But the idea behind these two trials, DECRA, which is out of Australia and New Zealand, Rescue ICP, out of a group at University of Cambridge, a wonderful academic group, in this trial specifically led by Peter Hutchinson. What they're trying to do here is very simply determine if decompressive craniectomy is going to improve outcome in patients with raised and refractory ICP. This study, as you can see, it's a process of care study. You're seeing if there's high ICP. You're using a variety of modalities to control it. If it's not working, you're randomized to continued medical therapy or surgical therapy. Rescue ICP will include patients with contusions. By contrast, DECRA, which comes out of the Australia and New Zealand Intensive Care Society, it is for edema without blood. Same hypothesis. You're going to reduce ICP, reduce secondary injury, and therefore improve outcome without seeing more vegetative survival. The inclusion criteria are stricter. These are patients simply with diffuse brain edema. And so, for example, this patient would not be entered into DECRA. There's blood on the CT scan. It's a prospective multi-center study. It's going to be single-blinded. The assessor will be blinded. Obviously, the caregivers would not be. The primary outcome, again, is the Glasgow outcome scale, the extended scale. It's a relatively small sample size based on some data originally from Australia. Other outcome measures will look at intracranial pressure, mortality, and so on. The treatment follows the Brain Trauma Foundation guidelines, just as Rescue ICP does. When you have refractory ICP, the randomization occurs. Here's the surgical technique. It's the standard Schellberg procedure, or the bifrontal craniotomy. They suggest a cruciate incision on either side. We're actually the only American center. I'll tell you, it took 2.5 years of legal negotiation with our legal department at Penn to get the study okayed. And this is one of the problems now with trying to do multi-center trials from an international basis. Many medical centers in the United States are reluctant to embrace trials that come from a group outside of the United States for the various medical legal implications. Most of the groups are here in Australia and New Zealand. We've been in the study for about a year. We've not been able to enroll any patient, partly because of the exclusion and inclusion criteria and our tendency to do decompressive craniectomy early. The target's 165. This is from a couple of months ago. I think it's up now to about 140 patients. Well, ICP monitoring might be the tip of the iceberg. Is there something else that we can do with multimodality monitoring? And if you think about this, this has evolved in the last several years as the Neurointensive Care Society has evolved. So the Neurointensive Care Society has its 7th annual meeting this year. And it's really been during that last 5 to 7 years that concept of multimodality monitoring has really driven neurocritical care. Central to that has been looking at oxygen and glucose. And we heard a talk about that recently and the importance of that to ATP metabolism. So is there value to looking at brain oxygen? There are studies looking at PET, MRI, or microdialysis that suggest an understanding of oxygenation may be very important in the care of traumatic brain injury. We have found that where you follow guidelines and resuscitate traumatic brain injury patients, we can normalize CPP according to the guidelines in about 95% of the patients. But a third still have hypoxia and up to 45% have compromised oxygenation. So we're not quite sure what's happening at the cellular level. Perhaps ICP monitoring tells us what's going through the blood vessel, but not what's getting out through the endothelium, across the interstitium, and into the cells. There's a lot of data to suggest, and this is a systematic review that will be, it's in Press in Critical Care Medicine now, No question that low brain oxygen is associated with both mortality and unfavorable outcome. Several large prospective observational studies have documented that. Again, the group in Cambridge and Ross Bullock and others have demonstrated that when you give more oxygen, you will improve metabolism in the brain. Now, whether that translates into anything clinically relevant still remains uncertain. Again, Ross has demonstrated, and this is an animal model, that you will improve ATP production following head injury when you give more oxygen. It may be a potential mechanism, and that's important in any form of therapy. We have found when looking at historical controls that there's a significant reduction in mortality and an improvement in favorable outcome with brain oxygen-based therapy, and that among those who receive brain oxygen therapy, they have a far shorter duration of brain hypoxia. All of these therapies are what we currently do in the ICU. There's nothing magical about it. Although David can comment on a vitamin A analog, I think that the University of Virginia was using at one point that seems to improve oxygen diffusion. So the NIH has now funded a phase 2 randomized trial running at 4 centers. It's going to enroll 182 patients. The primary hypothesis is simply physiologic efficacy. In other words, brain oxygen-directed therapy plus ICP therapy is better than ICP therapy alone at maintaining normoxia or preventing cerebral hypoxia. There is a non-futility hypothesis. What this is then developed is a study known as BOOST, which is a phase 3 study. There are 25 centers worldwide trying to recruit about 1,400 patients to look at an 8% minimal absolute difference. We've got a good group of external advisors, including Gordian Murray and Claudia Robinson and others. We're able to get David Warner, who is the physician protocol monitor in IHAST, which is the hypothermia trial and the aneurysm study. Basically, we'll do online compliance to ensure that there's standard management. This is now in review at the NIH. If they funded the phase 2, hopefully they will fund the phase 3. It's a simple process of care study, not unlike ODdsNet, which changed how pulmonary ventilation was performed. This study, which is spearheaded by Ross Bullock, again is a means of trying to maximize oxygenation in the brain with oxycyte or PFCs. When you give the PFCs, you improve the lactate pyruvate ratio. And when you see an improvement in metabolism, there's several centers that are involved around the world. I think this is on hold right now because of FDA issues, and Ross is pursuing this in Switzerland and Israel. Well, let's get outside the box. We tend to focus on what we can do acutely in the ICU, in the surgery. What about prevention? How about trials in prevention? For those of you who follow motor racing, this is Formula One racing. Don't see a huge amount of the United States. Biggest spectator sport worldwide. More people watch this sport than any other sport around the globe. 200 miles an hour, wheel to wheel, round a corner. This is the last guy to die, 1995. Actually, 1994, excuse me. So 15 years ago. So there's something about car design, helmet design, and a variety of other things that we should be looking at, because prevention obviously can prevent head injury and primary impact, and there's opportunity for that. What about concussion? You know, force equals MA, so Muhammad Ali hitting you versus a 20-year-old or a 20-kilogram young kid, you're obviously going to get a greater hurt for Muhammad Ali, and these are just some pictures from boxing, sports-related head injury. We know that even with mild head injury or severe head injury, over time you can start to see cortical atrophy, loss of neocortical volume. Can we get into restorative neurosurgery? Our role, perhaps, as trauma surgeons may well be in restoration and recovery, not necessarily prevention of injury or protection from cell death. These are Mueller glial cells with rod photoreceptors. You can see they're only growing on those astrocytes. Will it be cellular implants that will work? Could it be something else, like stem cells that lead to differentiation? Should we be doing implantation 6 months later? And exactly how wide is that therapeutic window? This is work from Doug Smith at our university. These are pigs about 18 months after head injury. You still see ongoing changes in the brain, and hence I would put to you, how wide is the therapeutic window? We talk about this 1 hour golden hour or the 6 hour therapeutic window for neuroprotectants. Maybe it's 18 months. Maybe we won't prevent the cell death, but if we do something later, we might be able to induce recovery and promote recovery. And here's some example of an EGF infusion where you see a far better improvement in the Morris water maze. So a very simple therapy. It might be something else. This is good data in the rat that demonstrates that an enriched environment, and specifically running, exercise, improves cellular function, both neurogenesis of new cells and also dendritic complexity. And as you know, dendrites are highly plastic. They are correlated with long-term potentiation and therefore cognitive function in rat models. You can induce dendritic arborization simply with exercise. And there's a variety of other tools. Again, the group at UCLA has demonstrated this. Part of that is through BDNF and other factors. You can still see neurogenesis in the adult brain, and that is promoted by exercise. There's a lot of interest by the National Institute of Aging in this question because it appears that both exercise and calorie restriction can delay the effects of aging, and part of the effects of aging are decreased cognition. And there was a recent randomized study that confirmed you could correct a cognitive abnormality with calorie restriction. There are animal studies suggesting that calorie restriction is neuroprotective, not insulin, but calorie restriction. So this opens up, I think, a large number of potential means of restoring function long term. These are some other drugs that are now in use, or other techniques in use to improve functional recovery, often in the mild and moderate. You'll see some of these coming online from the Department of Defense, like beta blockers and the statins, things like tele-rehab or telephone intervention, cognitive therapy. This is a nutritional supplement, and a variety of other drugs here for irritability, mood disorders, and anxiety disorders. I think importantly we have to recognize, 10, 15 years ago we talked about level 1 trauma centers. Within a level 1 trauma center, further organization, and that will be neurointensive care. Well documented that patients in a neurointensive care unit, where there's a collaborative effort between a neurointensivist and a neurosurgeon and a trauma surgeon, you will have better outcome. So not only level 1 trauma centers, but that institution of a neurocritical care service. It does seem that as you understand more about the physiology, you see a decline in mortality. Data from the Traumatic Coma Data Bank without a monitor, ICP monitoring, with the brain oxygen monitoring. And I'll put it to you that we don't know enough about the brain, its physiology and pathophysiology after injury. You come in a coronary care unit in the United States with a heart attack, you get 25 different kinds of monitors thrown at you as a routine. More than 200 drugs to treat the failing heart. More than 200, and a heart transplant. You come into many intensive care units in the United States, about 50% of us would get an ICP monitor. Not a lot of other stuff done, and in many other countries you don't. You try to name those 4 drugs that we have to treat the failing brain. And I put it to you, we need to understand more about the brain. We can do that. There are non-invasive techniques. We need to develop devices to understand the brain, to develop effective therapies. I'll leave you with this thought. It's a worldwide disease. It's a public health issue. That's the most valuable prize in all of sports. For those of you who follow football as it's correctly played with the feet and not with the hands, soccer, it's the World Cup. We can get to that level by understanding what happens to the brain, by monitoring the brain, by looking at physiology, by classifying traumatic brain injury according to the pathology rather than simply a system, by looking a little bit outside the box, thinking about prevention, taking neuroprotection to a longer therapeutic window, considering restoration and recovery. Thank you.